Hello, everybody. Welcome to this ACR TIRADS webinar part 3, Why Adopt ACR TIRADS, Evidence Behind the Performance. My name is Dr. Jenny Hong, and I'm a neuroradiologist at Duke University. Well, this is our final webinar. We've come with a box of tissues each, and this follows a webinar first on how we do it. So that was the how of ACR TIRADS. Then we had a webinar of commonly asked questions, and that was really more of the how, but also the what, the where, the when, and even the who of ACR TIRADS. And now with this final webinar, we're going to be talking about why. Why should you consider adopting ACR TIRADS and continue to use it? We are going to be reviewing some key articles here, and we're going to help you interpret them. And what we want you to get out of it is really for you to understand why you should be spending the extra time to change your practice and use ACR TIRADS, and if it is time well spent. I'm going to be introducing to you to our other speakers. We've got Franklin Tesler, who's a professor of radiology at the University of Alabama in Birmingham, and he was the chair of the ACR TIRADS steering committee. He continues to lead efforts on the international front, and he'll tell you more about that later on. We've also got Dr. Bill Middleton, who's a professor of radiology at Mallinckrodt Institute of Radiology, and he was a key member of the ACR TIRADS steering committee, and it was really his data that helped us make decisions on the ACR TIRADS model. And then there's me. I'm passionate about improving patient care directly day to day, but also through research and education, and I've really enjoyed being a voice on these ACR TIRAD committees. All three of us, now that we're on our final webinar, I'll have to tell you, are really very passionate and generally care about everyone adopting better practice for thyroid nodules. And we want you to be better armed with adopting ACR TIRADS if you choose to do so. And this is why we've devoted our time to putting all this together for everybody and answering questions when we get them. Now, one might think that a webinar on the evidence might be somewhat dry, but we have thought really hard about the format, and rather than presenting article after article, we've divided up the literature into just simple questions that you may wonder. So I'm going to tackle the first question of why to adopt ACR TIRADS. Then we'll have Franklin, who will be talking about ACR TIRADS features that are particularly challenging. He'll also talk about the differences between ACR TIRADS versus ATA and SRU. And he'll also talk about the size thresholds and the rationale behind that for ACR TIRADS and why it's different to the others. He'll touch on the question of why ACR TIRADS and ATA could or could not be used simultaneously. And then after that, Bill has a very big task of giving you some review of comparing ACR TIRADS to other risk stratifications, and that's through the work that he's done as well as some literature that's come out recently. And then finally, we'll talk about future plans for ACR TIRADS. I hope that you can stay for the full hour, and thank you for attending, everybody. This session will be recorded and made available anytime afterwards, as were webinars 1 and 2. These are available on the ACR TIRADS website. So first we have questions about you. Who are you? Are you a radiologist, a radiology trainee, physician, sonographer, patient, or other? And you can answer the questions on the GoToWebinar panel. And it seems that most people are radiologists, but thank you to the trainees and physicians and sonographers that have channeled in. The next question is, does your practice currently use ACR TIRADS? Yes, no, but will be in the next 6 months, and no in the near future. No, not in the near future. And it seems that the majority of people will be using ACR TIRADS or have been using ACR TIRADS. That's great. And for the others, maybe we can convince you. Okay, so my section is why adopt ACR TIRADS. And let me start off with a sample report that I received from a colleague of mine who is an interventional radiologist. This is his sister's radiology report for her thyroid ultrasound. And she's a attorney who had no palpable nodule. I don't remember why she got a thyroid ultrasound, but it led to an ultrasound report that had this that was rather short. It had a section on the technique, and a section, 2 paragraphs on an overview of the thyroid, and then 2 nodules described in this report in 2 lines. There was a nodule in the right lower lobe with a size characteristic of 7 by 4 millimeters, and then one statement about the nodule being hypoechoic. And that was the only way the nodule was characterized. And then another nodule uh, within the lower lobe, but the side is not mentioned here. And it is 4 by 3 millimeters. And once again, the echogenicity is characterized, and that was all. And then in the impression, we have several typos about the 1 centimeter nodule, and then of the other 4 millimeter nodule. And then the recommendation here was really an option. It was do a 6-month follow-up, which is really short from our point of view, and then, or that the person could have an ultrasound guided aspiration of the dominant nodule. And I think these terms of dominant are particularly scary for the patient. So aside from the typographical errors, this report doesn't really have a full description of the features that all societies use to characterize nodules, and the recommendations are rather ambiguous and also incorrect. And so that leads me to this article that just came up this week. It was published online, and it is an article that was from Canada, and these authors took 1,930 thyroid ultrasound reports, and they answered this very question about the quality of our radiology reports. Do we describe all the features to make a decision to use ACR TIRADS or any of the other risk stratification criteria? So they had 6 features that they were looking for. 5 of them are the descriptors used in ACR TIRADS, and then the 6th feature was the nodule size. They found that of the reports that were reviewed, the mean score out of 6 was 2.57. And then they determined that the nodule needed to have 4 or more features in order to actually correctly classify it with one of the risk stratification criteria. And shockingly, and even maybe not surprisingly, less than 14% of reports had these features in order for someone, an endocrinologist or a surgeon, to classify the nodule under one of the risk stratification criteria. So this sort of sets the tone of how thyroid ultrasound is done in North America. So why would you not adopt ACR TIRADS? I've heard many of these comments in participating in ACR TIRADS activities and doing talks. It's more time consuming to report all 6 features, right? Instead of maybe 2, as in that previous report, just the echogenicity and the size. There are too many radiologists to teach this new system to, and it's time consuming. We're all busy in our day-to-day work anyway. Some comments I've received are that the referrers don't like it. They think the reports are too long. And the referrers prefer another system, such as the ATA system, or they just like the way we did it in the past. And then finally, the sonographers don't feel confident about using ACR TIRADS. Then why would you adopt ACR TIRADS? And then this really gets to the crux of my next couple of slides. It gives you better patient care, and that's through improved quality of the report, and also the fact that ACR TIRADS performs better compared to no criteria or other criteria. Specifically for improved quality of the report, it gives you a better descriptor of the findings of the nodule so that ACR TIRADS or other risk stratification criteria could be applied. It makes the recommendations more standardized and it reduces variability. So let me talk about that in this paper. This was a paper that was published in JACR in May, so just this month. It is about improved quality of the thyroid ultrasound reports after implementing ACR TIRADS. This was a study that was done with radiology partners. And in this study, we implemented this new structured reporting template, which had the nodule number and the size and the location, a descriptor of the nodule features. This is a pick list, so not all of this text appears. It's just solid if it's solid, echogenicity, hypoechoic if it's hypoechoic. So it's not usually this busy, but it lists all of the 5 features under ACR TIRADS. And then it gives recommendation for the total points and the TIRADS classification. It talks about a change in the nodule if there was a previous ultrasound, and then it gives a recommendation. Now, in this study with radiology partners, the first phase was just looking at the text reports without implementing this structured reporting template. The second phase was using the first half of this template, so just the location and the size and the descriptor. And then in the third phase, after ACR TIRADS was published, we introduced the next part of the structured reporting template. So we evaluated amongst these radiologists what happened if we used a structured reporting template with the features and what happened if we implemented ACR TIRADS. And in each of these 3 phases, phase 1, 2, and 3, we looked at the recommendations in the radiology report. And there were 4 options that we saw, that they would recommend a biopsy, that the radiologist would recommend an ultrasound, a follow-up ultrasound, that there would be a recommendation that the nodule needed no follow-up or biopsy, or that there was nothing said about the nodule, no management recommendation. When I first started doing the study, I really thought that we would see fewer nodules being biopsied with ACR TIRADS, but that's not what we saw. There was actually no statistically significant difference in the nodules recommended for biopsy with ACR TIRADS, with the template, or with the final recommendations. So that was surprising in the early phases. But what we did see is that after implementing ACR TIRADS, the improvement really was that there were far fewer nodules with no recommendations. You can see without ACR TIRADS and a RADS system, a third of nodules had no recommendation of what to do. And what does this lead to? Well, it leads to the referrer and the patient being confused and maybe more likely to have biopsy or follow-up when it wasn't necessary. Now, in the next part of the analysis, we looked at the frequency of specific findings, the 5 findings under ACR TIRADS. And we saw that in phase 1, when there was just free text, that the reporting, particularly of shape, margin, and echogenicity, were very infrequent. When we implemented the structured reporting template, there were actually fields that they had to fill out. So in phase 3, all of these features were reported, whether they were present or absent. And now when we looked at the frequency of the suspicious features, this was revealing of why there were the same amount of biopsies. In phase 1, when it was just free text, the frequency of taller than wide, suspicious margin, and punctate echogenic foci were relatively low. But we saw that in phase 2 and 3, when the radiologist had to create a checklist and look at these features in the nodule, the frequency of these findings, these suspicious findings, were actually much higher. So it shows us that in phase 1, just because the radiologist didn't mention these features wasn't because they weren't present. It probably was because they weren't specifically looking and didn't see them. And as a result, the average ACR TIRADS points was higher in phase 2 and 3 compared to phase 1. And that is why in phase 3, the same number of biopsies were recommended. It's because radiologists saw more nodules with these suspicious features that would appropriately be recommended for biopsy. So the take-home point from this study is that a structured reporting template serves as a checklist, and that ACR TIRADS results in more definitive recommendations. A next study that talks about reducing variability is a study that we did that looked at Interobserver variability. And Franklin is going to talk about this article in more detail. So I'm going to skim over this, but what I want to point out is that we looked at various sonographic features, and we saw that margin and punctate echogenic foci had the poorest agreement. It was a fair, and that an overall recommendation, if radiologists weren't given ACR TIRADS, was fair, verging on slight. But with ACR TIRADS, no matter how radiologists varied in their interpretation, it actually improved the recommendations being more consistent. It was now having a kappa of 0.51, which put it into the moderate agreement range. So in this study, we had high variability in interpreting several ACR TIRADS findings, but applying ACR TIRADS reduces the variability. And then the final paper that I'll talk about is one that was published in Radiology in April of this year. This study took 8 radiologists who interpreted 100 nodules, the same nodules, and these radiologists were asked to provide recommendations for biopsy as well as interpret the features of the nodules. In addition, we had 3 experts that interpreted the same 100 nodules as the gold standard in interpretation. And this study really talks about the reduction in thyroid nodule biopsies and improved accuracy. When radiologists were asked to categorize the nodules from benign to highly suspicious before knowing about ACR TIRADS, this is in the pink color, most radiologists thought nodules were mildly suspicious. Now, I think this is a really good sign of radiologists being unsure and hedging, being in the middle ground. After we used their nodule interpretation and applied ACR TIRADS, we can see that many more nodules were moderately or highly suspicious. And this makes a lot of sense because these group of nodules were nodules that were all biopsied. So they were more suspicious than the everyday diagnostic ultrasound thyroid nodule. Now, despite more radiologists saying that nodules were mildly suspicious, we found that compared to radiologists' own judgment, ACR TIRADS applied to their own interpretation would have reduced the number of thyroid nodule biopsies from 80 to 57. Now, with fewer biopsies, how did this affect the sensitivity and specificity? This was the sensitivity and specificity and accuracy on average for the 8 radiologists. And this was the sensitivity, specificity, and accuracy after applying ACR TIRADS to their interpretations. You can see sensitivity doesn't change significantly, but specificity certainly does. It improves from 20 to 44%, and accuracy markedly improves as well. We then use the expert interpretation and compared it to other risk stratification criteria, and we found that ACR TIRADS has the same sensitivity as other categorization guidelines out there, but the specificity was definitely better and the accuracy was better. And Bill has a larger study that looks into this, so I'm going to move on. I do want to emphasize that what does it mean to miss a malignancy? It doesn't mean that the malignancy was missed because of an incorrect interpretation, but there are certainly even high suspicion nodules that don't meet the category for biopsy because they're too small. And we definitely covered this in the past webinars that we're aiming to biopsy nodules that are suspicious, but also result in a significant outcome in that if they're untreated, they'll lead to harm for the patient. And as we know, thyroid cancer is very indolent and there are many cancers that don't progress and can be safely observed. But this table shows the 5 thyroid malignancies that had a recommendation not to biopsy by one or more observer. And we see here that there are 2 radiologists in particular that did not recommend follow-up for malignancies. and therefore these malignancies wouldn't be observed in their annual follow-up. And this represents just two malignancies here, and only 3 out of 120 malignancy encounters, and so 2.5% of malignancies. And here the problem was misinterpreting a solid nodule with some cystic components as spongiform or mixed cystic solid. So in this study, we identified definitely composition as an area to focus on. So the take-home point from this article is ACR TIRADS reduces a number of thyroid nodules biopsies when compared to radiologists' existing practice patterns and other criteria, and that applying ACR TIRADS improves the specificity and accuracy due to reduced number of benign biopsies. So to conclude my section, using ACR TIRADS does provide better patient care. It improves the quality of the report, even if we're not looking at outcomes of whether the nodule was malignant or benign. It gives us a better descriptor of the findings if we use a structured reporting template. It makes the recommendations more standardized, that is, radiologists are more consistent with each other in their recommendations, even if they report the nodule differently. And then it reduces the variability in the recommendations. And then the other advantage is that ACR TIRADS does have a better performance compared to no criteria or compared to other criteria. And Bill will be reviewing his studies as well as some of the studies performed in Europe since ACR TIRADS was published. And so I'm going to hand it over to Franklin now to do his section.
Thank you, Jenny. And as soon as I have control, I'll go on to the next slide. To start off with, since publishing ACR TIRADS, we've heard from radiologists and other practitioners in multiple places saying some of what Dr. Hong alluded to, which is that they're struggling with some ACR TIRADS features because they're reporting them and looking at them for the first time. So my first question is, which ones are the most challenging for sonographers and physicians to deal with? And as I alluded to during the last webinar, there are a number of features that seem to give people more problems. I specifically talked about mixed solid and cystic nodules being problematic, and I talked about comparing a mixed nodule that has a roughly even distribution like the one on the left versus one with eccentric solid material like the one on the right. And this is based on my anecdotal experience. But I'd also like to talk about this in the context of variability that Dr. Hong also presented a little bit earlier. And that is the importance of interobserver variability. Stated another way, ultrasound features aren't helpful if observers don't agree on whether they're there or not. For example, if one observer says that a nodule is very hypoechoic and another says that a nodule is hyperechoic, they'll receive different scores and be subjected to different management recommendations. Interobserver variability was assessed in this paper that Dr. Hung was lead author on, and this is the paper that she showed with 8 board-certified radiologists looking at 100 proven nodules, assessing their agreement on feature assignment and biopsy recommendations based on their practice. And this is a section from the same table that Dr. Hong just showed, and highlighting that some features, notably margin and punctate echogenic foci, had low kappa values indicating high interobserver variability. Not surprisingly, macrocalcification, which is usually pretty easy to determine that it is present or not, had a pretty good kappa value, and the others were in between. So what do you do with this? We look at this table and say there are some features that people can't agree on. Where do we go? There are basically two routes that we can take. The first would be to eliminate or change the definition of some features. Unfortunately, these features have all been shown to have utility in distinguishing benign from malignant nodules. Therefore, doing this would not be productive. The alternative, and this was the conclusion in this paper, is to apply more education. And this is something that we're doing by means of these webinars, by means of publications, and it's something I'm going to touch on in the end when I talk about the future of ACR TIRADS. But the key point is that decreasing interobserver variability requires people to look at nodules, look at features, and one thing that, and try to increase their confidence that a feature is there or not. And one thing that really helps in practices is have several observers review cases and look at nodules and see if they agree on whether features are present or absent to try to improve their interobserver agreement. The next question, which I'll spend a little more time on, is what are the major differences between ACR TIRADS compared to the American Thyroid Association and the SRU recommendations? And I chose those two because the ATA recommendations are frequently requested, particularly by our endocrinologist referrers. And the SRU recommendations I chose because many practices are still using them, particularly in radiology practices. At the highest level, really, there are a few differences. All the risk stratification systems start with imaging, then progress to characterization of nodules, and finally come up with management decisions. So this is at a very high level, so-called 50,000-foot view. But there really are differences when you zoom in. Let's start off with imaging. Well, you'd think that imaging is imaging, right? But the truth is that there are some distinctions between the systems that are highlighted in this table. Starting off with the number of nodules to scan a report, ACR TIRADS specifies up to 4. And by this, I mean that this is the maximum number of nodules that are formally reported and for which all the features are enumerated and they are classified. It doesn't mean that you don't see the other nodules. It just means you pick up to 4 to formally document in your report. Neither the SRU nor the ATA guidelines state a limit. And we chose this because we thought it was something that could be applied practically in a typical ultrasound practice. There are slight differences in measurements. Both the ACR TIRADS system and the ATA specify that nodules should be measured in 3 dimensions. Interestingly, the SRU doesn't really talk about 3-dimensional measurements, although it refers to the maximum 2 measurements, and that indicates the maximum measurement of a particular nodule. There are more differences in the characterization step. ACR TIRADS began with a feature lexicon that was published in 2015. I'll show more about that in a moment. And we did that because we wanted to have a basis on which ACR TIRADS classification would be founded. Neither the SRU guidelines nor the ATA guidelines specifically referred to a lexicon of ultrasound features. In fact, in both of them, it was sort of assumed that a particular feature that was listed as a criterion, you would know when it was present or not. And we felt that having a lexicon with examples was an important foundation for what we were doing. Of course, there are differences in how risk assignments occur in the 3 systems. ACR TIRADS points assigned in 5 feature categories compared to a tabular method for the SRU based on composition and size. And by composition, I refer to all the internal characteristics of a nodule. And for the ATA, patterns of appearances and composition and size. And finally, lymph nodes, which are not formally considered in ACR TIRADS and were considered by the SRU and ATA. And this is the front page from the lexicon paper from 2015. And here's the table of the 5 feature categories that you see here on the left. And I've outlined the the more suspicious categories in red that I'm highlighting here. And these were translated into the well-known by now ACR TIRADS table, or chart, which I won't go through in detail, the 5 categories in which you choose one in each of the first 4, and then all that apply in the last one, add up the points and combine that with the size to come up with a TR level ranging from 1 to 5, and decide based on that whether to recommend an FNA or follow-up. Compare that to the SRU table on the left and the ATA on the right. On the left, we see that this SRU table showed these different appearances, and each of those was associated with a management recommendation. In essence, these are really patterns. The ATA is definitely pattern-based. You basically take the nodule that you're looking at and try to match it as closely as you can with one of these patterns in the chart. And as you go up in the chart from bottom to top, the suspicion level and the recommendations for biopsy change. The problem with patterns that we've highlighted in previous webinars is that not every nodule fits a pattern. In fact, in one recent study of 2,000 nodules, 100 or 5% were not classifiable by the ATA guidelines, and those nodules had a 19% malignancy rate. There are even greater differences in management between the systems. The size thresholds, particularly, ACR TIRADS specifies thresholds of 2.5, 1.5, and 1 centimeter at TR3, 4, and 5. The SRU talks about either strongly considering or just considering biopsies depending on features and size. And the ATA says FNA or consider FNA depending on the pattern and size. Follow-up in ACR TIRADS, as I mentioned earlier, is specified as each TR level. So if you have a nodule for which FNA isn't needed, you know whether to recommend follow-up or in some cases no follow-up. And the SRU had no specific recommendations for follow-up intervals, and the ATA's recommendations are limited. As I mentioned earlier, lymph nodes are not formally considered in ACR TIRADS, although we said that lymph nodes should be biopsied if abnormal. The SRU said ipsilateral nodules should be biopsied if there's an abnormal lymph node on that side, and the ATA said to biopsy an irregular nodule if there's a suspicious node. The differences are highlighted in this chart from a recent paper in radiology that compared these 7 systems, and I've highlighted the sensitivity, specificity, and accuracy for ACR TIRADS, and you can see how that compares to the others. We knew in designing ACR TIRADS that our sensitivity would be lower than other systems, but you can see that our specificity and our accuracy were considerably higher, and Bill will talk about this shortly. Why does ACR TIRADS specify larger size thresholds for FNA of some nodules? Going back to the pattern system in the ATA guidelines, you can see all the patterns and the different size thresholds as you go up in suspicion. If you overlay on that the point levels, you can see that, for example, at the high suspicion levels, most of the nodules would be classified as ACR TIRADS 5, and would be biopsied in ACR TIRADS at a threshold of 1 centimeter, concordant with ATA. This pattern, hypoechoic with irregular margins, would be classified as TR4 and biopsied at a 1.5 centimeter threshold. Similarly, for intermediate suspicion nodules, which would both be classified as TR4, the ACR guidelines would biopsy at 1.5 centimeters versus 1 centimeter for ATA. At low suspicion, TR3, these two TR3 nodules would be biopsied at a threshold of 2.5 centimeters in the ACR TIRADS compared to 1.5 centimeters for the ATA. What underlies our decision to use larger size thresholds? And the questions we looked at what sizes do nodules become problematic? And are ultrasound measurements, in quotes, accurate? Because accurate is a relative term. Many of the other guidelines, including the ATA, base their recommendations for size on this study from 2005, which looked at gross tumor size versus risk of metastases. And they said in this paper that there was an abrupt takeoff at 2 centimeters. However, they were using gross tumor size, and I'll talk more about that in a moment. Since then, Dr. Nguyen and several of us published a paper in Thyroid earlier this year, and we found no threshold effect on risk of distant mets or nodal mets or local invasion for tumors less than 4 centimeters. And moreover, didn't find a great change in mortality until the size was greater than 2.5 centimeters. As well, previous research showed that ultrasound measures nodules by an average of about 5 millimeters. And we took all these things into consideration in our larger size thresholds. As well, the fact that we supply follow-up recommendations mitigates the likelihood of us missing a cancer over the long term. Finally, can you use ACR TIRADS in the ATA guidelines simultaneously? Well, yes, you can, but you need to be prepared to deal with discrepancies. And those are highlighted again in the ATA chart showing the nodules for which there would be significant discrepancies between the ATA and the ACR TIRADS guidelines. If you report both, you have to be prepared to deal with referring physicians who are going to notice the discrepancies. And since patients get to see reports more often than they used to, in fact, it's becoming the norm, they would often have questions. So with that, I'll turn the control over to Dr. Middleton for his presentation. Thank you.
Okay, this is Dr. Middleton speaking from Mission Control. So my assignment was to compare the results of the ACR TIRADS to other existing stratification systems. And I really want to focus on 3 specific studies, a little bit on a 4th if we have time. This is the one that I will start with, and it comes from the Society of Radiologists and Ultrasound, who developed a group of investigators that looked at nodules between 2006 and 2010. It was a group of 6 different academic medical centers. And I'm focusing on this article first because it's the largest of the existing comparisons, and also because the first author is a very close and personal friend of mine. So the cohort was 3,400, about 3,400 nodules that had definitive FNA and or histology results. We looked at all these nodules and retrospectively determined their ultrasound features, features that you all are familiar with now. And then we classified each nodule based on the ACR TIRADS from 2017, the Korean TIRADS from 2016, and the ATA guidelines from 2016. So of the 3,400 plus nodules, a little over 3,000 were benign and 352 were malignant. And you can see the breakdown of the different types of malignancies that were included. Majority were papillary or the follicular variant of papillary cancer. And then for each one of these nodules, we divided them up into categories depending on what each classification scheme would place them. So they would either place them in a FNA recommendation, a follow-up ultrasound recommendation, or no further evaluation recommendation. And this is a chart that shows the breakdown of where the nodules were classified on the different systems. So up here at the top are the relatively innocuous looking nodules, very low suspicion, benign lesions, and the TR1s and 2s for the ACR TIRADS. And then as we move down, we get into the more suspicious nodules. And you can see that there's a large number of nodules in each one of these categories. But what I really want to focus on is the non-classified nodules. So notice that in the ACR system, there were no nodules that could not be classified. On the other hand, in the ATA and the Korean classifications, there were at least a substantial minority of nodules that could not be classified, particularly in the ATA guidelines. And when we just focus on those guidelines, we found, as Franklin mentioned earlier, that there were 14% of the ATA nodules that could not be classified into any of these risk categories. And of those, 9% were malignant. And that's a fairly significant minority of the non-classified nodules. And then if you just look at all malignant nodules, 13% of them were not classified based on the ATA guidelines. And here's a chart that I do want to spend a little bit of time with. So it looks at the ACR, the ATA, and the Korean guidelines, and it looks at these different parameters. So ACR has definitive recommendations for which nodules should be biopsied and which nodules should be followed, and then leaving the rest of the nodules as nodules that don't require any further evaluation. The ATA has spotty recommendations about which nodules should be followed. Korean guidelines don't have any recommendations about follow-up. So I'm just going to focus to begin with on the biopsied categories. We'll talk about followed categories later. So in this first row, yield of malignancy, that refers to the number of biopsied nodules that turn out to be malignant. And you want that to be high. You want to have as many nodules that you're biopsying be malignant and as few nodules as possible be benign. You want your yield to be high. And as you can see in this study, the ACR yield was higher, substantially higher than either the ATA or the Korean yield. In the next row is another statistic, and this is the percentage of malignant nodules that would be biopsied using the different systems. So this is a number that you want to be high. You want to biopsy as many of the malignant nodules as possible. In the ACR system, it was 68% and a little bit higher, significantly higher in the ATA and the Korean systems. And this is something Franklin mentioned earlier, and this is something we expected all along when we set up the guidelines. If you just look at the nodules that are greater than a centimeter, greater than or equal to a centimeter, then that sensitivity or that percentage of malignant nodules that are biopsied increases quite a bit to 83%. It also increases with the other systems, and there remains a significant difference between the three. Then we move on to this next row where we focus on benign nodules. So the percentage of benign nodules that are biopsied in the ACR system is 47%. You want this number to be as low as possible. You'd like to biopsy as few benign nodules as you can. And in our study, this was significantly lower than either the ATA or the Korean systems. And again, if you just look at nodules that are bigger than or equal to a centimeter, assuming that anything less than a centimeter is not significant regardless of what it is, you see these statistics, that the ACR biopsies 50% of the benign nodules that are greater than or equal to a centimeter. ATA and the Korean systems biopsy a little more than 80%. Okay, so next let's focus on these followed nodules. So since the ACR does give discrete recommendations on what should be followed, I wanted to look at this as well. And of the nodules that would receive this recommendation, about 12% turned out to be malignant. Of all the malignant nodules, about 21% would be followed under the ACR criteria. So if you look at this, if you add these two numbers up, that's almost 90% of the malignant nodules would either be biopsied or followed under the ACR system, which is higher than the number that would be biopsied under ATA or Korean. If we just look at the malignant nodules greater than a centimeter, 11% would be followed. If we look at benign nodules, 18% would be followed. And again, if you add these two numbers up, the total continues to be less than the nodules that would be biopsied with the ATA system or the Korean system, much less the nodules that would be followed with those systems. Now let's talk a little bit about the ATA follow-up. So ATA does have some guidelines for follow-up. If you look at all the nodules that did not meet guidelines for biopsy, and that's a small percentage in this study, only 22% of nodules didn't meet guidelines for biopsy by the ATA recommendations. But of these 756, 55% had no recommendation either for or against follow-up. 16 of those were malignant. 11% had a recommendation for follow-up in 6 to 12 months, and 41, or half of those, were malignant. 27% of these nodules that didn't meet guidelines for biopsy had a recommendation to consider follow-up in 12 to 24 months. I'm not sure what referring clinicians do with a recommendation to consider follow-up, but of those, 26 were malignant. And there were only 50 nodules out of all of those where there was a recommendation for no further follow-up. Now, those 50 nodules account for just 1.5% of all of the nodules that were evaluated. So only 1.5% had a definitive recommendation for no further evaluation, i.e. no biopsy or no follow-up based on the ATA guidelines. Now, you compare that to the ACR guidelines, 32% had a definitive recommendation for no further evaluation. So compare those two results. ACR leaves you with final recommendations of no further resources need to be wasted on 32% of nodules. In the ATA, it's just 1.5% of the nodules. So the conclusion from this study was that the ACR TIRADS compares favorably with the other systems. The ACR system has a higher biopsy yield of malignancy, primarily because of reduced number of biopsies of benign nodules. It also eliminates further evaluation, i.e. biopsy or follow-up, of a much higher number of nodules. The ATA and the Korean systems result in biopsy of a higher percentage of malignant nodules, but this difference is at least partially mitigated by the follow-up recommendations included in the ACR system. So the next paper is one that Franklin has referred to a couple of times. This comes from a group of Korean radiologists who looked at 2,000 nodules, and they compared the diagnostic performance of 7 different society guidelines. Of their 2,000 nodules, about 1,500 were benign, and the benignity was proven by surgery or histology in a small percentage, by a benign biopsy with a repeat biopsy that was also benign in a smaller percentage. And most of them had benign biopsies to begin with and then were followed for 12 months. So very good proof that these were benign. There were 454 malignant nodules, and almost all of those were ultimately proven surgically. And you can see the breakdown of the types of malignancies. Again, papillary and follicular variant of papillary cancer were the most common. And these are the standard statistics for the different societies. So this is the ACR, the American Thyroid Association, American Association of Clinical Endocrinologists, the National Cancer Comprehensive Network, French Society of Endocrinology, Society of Radiologists and Ultrasound, and the Korean Thyroid Association. And if you just look at sensitivity, you want that obviously to be high. And as we've said before, that's one of the things that is lower with ACR TIRADS, lower than most of the other systems. Specificity, on the other hand, is one of the strengths of the ACR. And as you can see, it had the highest specificity of all of the guidelines. Positive predictive value, obviously you want that to be high. And in fact, it was the highest in the ACR guidelines. And negative predictive value, you want that to be high as well. And that was fairly similar in all of these categories. There was a little difference in the negative predictive value. And overall accuracy, again, was highest in the ACR system compared to all the other systems. So it performed very well when compared to many other established guidelines. And then these authors also evaluated the systems in a manner somewhat similar to the first study that I talked about. They looked at the total number of nodules that would require biopsy based on the different systems, and you can see the ACR recommended biopsy in the fewest number of nodules of all of these. The yield of malignancy and the yield of benignity Also, very similar to the previous study, you want the yield of malignancy to be high, and it was the highest in the ACR, the yield of benignity to be low, and it was the lowest of all the possibilities. And then they also looked at something called unnecessary FNA rate, and that was defined as the number of benign biopsies divided by all of the nodules in the study. And again, that's something that you would want to be as low as possible, and in fact, it was as lower than any of the other guidelines. And then they also looked at false positive rate, and I show this just because the false positives were lowest in the ACR guidelines, but they don't really define how they the formula they used to calculate that. So I take that with a little bit of a grain of salt. And then the final big study that's come out since the TI-RADS was published is from a group of primarily endocrinologists from Italy. And they looked at the performance of the ATA, the AACA, and the ACR systems in identifying cytologically high-risk thyroid nodules. And they looked at a little more than 1,000 nodules. Fine needle aspiration was used as the gold standard. There was no surgical or histologic correlation in this study. They had over 900 nodules that were benign, and they had 113 nodules that were presumably malignant based on high-risk cytology. So some of these categories that were in the benign category and in the high-risk category fell into cytologies that were indeterminate. They divided the indeterminate cytologic results into low-risk indeterminates and high-risk indeterminates. So they assumed that all of these would be malignant and all of these would be benign, but clearly that's not the truth. The majority in each case would be true, but not all of them. So the manuscript reviewer and me would have raised a lot of red flags about this way of defining nodules. Nevertheless, they did provide some useful data. And this, again, sort of highlights the fact that there are non-classifiable nodules in both the ATA guidelines and the AACE guidelines, 5% in ATA and 2.8% in the AACE. And of the ones that were non-classifiable in the ATA, 9 were cytologically high risk. ACR, again, was able to classify all the nodules. And the primary reason that I wanted to review this article is they also showed receiver operating curves for the 3 different systems. And for those of you that are familiar with this, I won't spend too much time with it, but this is a plot of sensitivity on the vertical axis and 1 minus specificity on the horizontal axis. And for receiver operating curves, you want the curve to be as far above this dotted line as possible. You want it to be in this upper left-hand corner as much as possible. And you can quantify that by calculating the area underneath the curve. And as you can see here, they've done that. The little triangular line, or the line with the triangles, is the ACR system. The line with the black boxes is the AACE, and the line with the gray circles is the ATA. And you can see that the area under the curve is the best for the ACR TIRADS. So in conclusion, they wrote this, that their study shows that the ultrasound classification system proposed by the ATA, the AACE, and the ACR differ in their ability to identify nodules at high risk of malignancy. In particular, the ACR TIRADS classification system has the highest ROC area under the curve for the identification of high-risk nodules and is the only ultrasound scheme able to classify all thyroid nodules. Their results also confirm a relevant limitation of the AC or ATA classification, which leaves unclassified nodules at relatively high risk of malignancy. So based on the current evidence, there are some conclusions that you can make. First of all, the ACR classifies all nodules. It's the only system in most of the existing systems that will classify all nodules. The ACR TIRADS reduces the total number of nodules requiring FNA or follow-up compared to other systems. And the ACR TIRADS reduces the number of benign nodules requiring FNA or follow-up. ACR TIRADS will miss more cancers than most other systems, but many of those missed cancers are less than a centimeter in size, and many of those that are missed will be followed for 5 years based on the follow-up recommendations in the ACR TIRADS. So that's really all the time that I have. We do have a few more points to make, and I'm going to turn the controls back over to Franklin.
Thank you, Bill. And in the last few minutes, I want to talk about where we're going next. So you've heard a fair bit this morning about ACR TIRADS versus other systems. But we have to remember that this isn't a contest. We all have the same goal, which is to reduce the number of biopsies of benign nodules while detecting appropriately malignant nodules. There are more similarities between all the systems out there than there are differences. So to paraphrase Rodney King, can we all get along? I think the answer is yes. And to that end, I started a grassroots effort. We're calling ourselves the International Thyroid Nodule Working Group. Our first teleconference was held 1 week ago, and although it makes it look like we spent 2 days on this, it was really 70 minutes. The 2 dates are because of the different time zones involved. And this involved 17 radiologists, endocrinologists, and surgeons from all the countries that you see here. And this was an organizing call to decide where to go next. But we agreed that our ultimate aim is essentially a universal TIRADS. We're going to do other things as well. For example, we're going to look at creating an internationally available atlas of ultrasound features to answer the educational question or issue that I mentioned earlier. And I don't know, as I speak to you this morning, where this will go, or now this afternoon rather, where this will go. But I'm hopeful that this will be a good cooperative effort. It's not going to be done quickly within a few months. It's going to take time. But both Drs. Hung and Middleton were on the call, and I think they would share my enthusiasm for what was expressed by thyroid experts from around the world who said that we should work together and try to reach consensus. So with that, I'll pass control back on to Dr. Hong to conclude.
Yes, and the other initiative we have is a multi-center thyroid ultrasound registry that's grant funded from the ACR and Akron with 6 practices, both private and academic, being involved. This registry eventually, this research registry will eventually be a practice registry so that your sites can participate as well and get some benchmarking nationally of how you're performing with regards to biopsy rate, malignancy rate, and then the frequency that you're interpreting these findings. So that is the other aspect of looking forward with ACR TIRADS, gathering more evidence to compare it to other risk stratification criteria out there. Well, we're on to our last 2 minutes. I wanted to show you the website for ACR TIRADS, which will have links to publications as well as links to all of the webinars that we've had. This is the Thyroid Ultrasound Registry and the participating sites, and I'd like to thank them for their participation. The recording will be available. All of the webinars, how we do it, frequently asked questions, and evidence behind ACR TIRADS will be made available. I would like to take this moment to thank Lauren Hicks from the ACR for coordinating and managing these efforts. Again, with this webinar, she'll have the questions and the timestamps of when they appear on the webinar. Franklin and Bill did a fantastic job in simplifying the literature and making it digestible. I'm certainly grateful that we left enough time for Bill to most eloquently describe and compare the risk stratification guidelines. Franklin, that chart on TI-RADS superimposed on the ATA chart was wonderful. I think all practices should have that up in their reading room if their referrers like ATA guidelines. So that is it. Thank you to everyone. Bill Franklin, do you have any additional comments?
No, I just would like to add my thanks to Lauren for her invaluable assistance in getting these organized. And it's been fun, it's been interesting and educational, and I hope valuable to people who've watched these webinars.
Thank you, everybody.
I second all of those motions.
Right. Thank you. Thanks for spending an hour with us.
Bye-bye.
Bye-bye.
Bye.